All right. Hello, everyone. Welcome to my presentation. My name is Athena LaPorte, and we will be discussing gastroesophageal reflux disease, or in other words, GERD. Now let's get to it. Overview of GERD. GERD is a chronic condition. Stomach contents flow backward into the esophagus, which then causes irritation or damage to the lining. There are three categories or types of GERD that you may see. There's non-erosive, erosive, and Barrett esophagus. These three are usually distinguished through an endoscopy. GERD is a multifactorial disorder. There are both physiological and lifestyle factors that cause it, which we will dive deeper into on the slides to follow. And a little history lesson here. GERD dates back to the 1400s, surprisingly, so it's been around for a long time. The understanding of digestion and reflux date back to when Leonardo da Vinci's drawings of stomachs and the intestines in the 1400s. In the 1500s, a German healer linked digestion to alchemical or chemical laboratory ideas. By the 1600s, Jan Baptiste van Helmont proposed the first chemical explanation of digestion. And lastly, in the 1800s, gastric acidity was recognized scientifically. The first modern reports of reflux disease appeared in 1935, and they were described as peptic esophagus. The prevalence has increased over the years. In Western countries, specifically Europe and North America, the prevalence of GERD is substantially higher than in many parts of the Eastern countries, such as Asia. GERD affects about 20% of adults in Western countries, with the U.S. prevalence ranging from 18.1% to 27.8%. While rates are slightly higher in men overall, studies show that women report GERD symptoms more frequently and are more likely to have the non-erosive reflux disease, whereas men are more prone to erosive esophagitis and Barrett's esophagus with long-term GERD. So the definition of GERD, according to the Montreal definition, GERD is a state with irritable symptoms and side effects brought on by the reflux of stomach contents into the esophagus. There are many mechanisms that contribute to the pathology of GERD. For starters, defective anti-reflux barrier. GERD primarily results from the dysfunction of the gastroesophageal junction, which includes a lower esophageal sphincter, also known as LES, and a crural diaphragm. The anti-reflux barrier's failure leads to backward flow of gastric contents into the esophagus. Next, transient lower esophageal relaxations, also known as TLESRs. This is the most common mechanism for reflux. It's an inappropriate transient relaxation of the LES, not triggered by swallowing, and it allows acidic or non-acidic material to move upward. Hiatal hernia. I'm sure many of us have heard this one before. It's an anatomical disruption due to hiatal hernia, which weakens both the LES and the crural diaphragm. It increases reflux, and it's also present in the majority of GERD patients. Impaired esophageal motility. An ineffective esophageal peristalsis limits acid clearance from the esophageal lumen, prolonging mucosal exposure and damage. And lastly, delays in stomach emptying increase the risk and volume of reflux events. Risk factors of GERD. A lot of risk factors that we'll be going through are modifiable and really depends on the patient trying their best to change their habits, that they're, um, sedentary lifestyle. It's important to ask whether the patient is exercising or if they consider their work as exercise. Low fiber, high fat diet, what are they eating during their meals? Are you notice any trigger foods that could be causing the reflux? Smoking is a big one. Alcohol, depression, obesity or overweight individuals. Again, hiatal hernia, certain medications such as antidepressants, calcium channel blockers, sedatives, and some medications are used to treat asthma. And lastly, pregnancy. Hormonal changes, especially late in pregnancy, and the increased abdominal pressure promote reflux. And here on the right, you'll see a picture of healthy esophagus and stomach versus someone who has GERD. And you'll see how the sphincter is open. There's like a slight opening that is allowing the acidic contents to flow backwards, while in the healthy individual, the sphincter is closed and there's nothing allowing the contents to flow backwards. Etiology. So the lower esophageal sphincter may relax too often or not maintain enough pressure, making it easier for stomach contents to travel upwards. Structural changes, again, like hiatal hernia, which we've mentioned a couple of times already, weaken the physical barrier between the stomach and esophagus. It increases the risk of reflux. Oh, so sorry about that. Extra pressure inside the abdomen, such as from patients that are overweight or obese, they can force the stomach contents past the LES and into the esophagus. Conditions like pregnancy can also raise the abdominal pressure internally, contributing to an increase in reflux. When the esophagus does not move properly or its muscle contractions are ineffective, it struggles to clear away the reflux material. This prolongs exposure and injury. Reduced saliva production means fewer alkaline secretions available to help neutralize acid in the esophagus. And lastly, defects in the esophageal lining, such as weak cellular barriers or impaired blood flow, lower the ability of the tissue to resist acidic injury and heal itself. These dysfunctions combine to overwhelm the natural defenses of the esophagus, allowing GERD to manifest and progress. So typical symptoms that you'll see in a patient that may be exhibiting GERD symptoms are heartburn and regurgitation. Heartburn is the most prominent symptom. Patient will describe this as burning pain rising behind the breastbone, often noticed after meals, lying down, or bending over. Usually happens about 2 or more times a week. Regurgitation is also common. It's the effortless movement of acidic or bitter stomach contents back up into the mouth, which can sometimes be worsened by postural changes, again, like bending, lying down, or after eating. Chest pain, esophageal chest pain may mimic cardiac pain, usually worse with activity after eating, described as substernal squeezing burning pain that radiates to the back, neck, jaw, or arms. This can last minutes to hours. Dysphagia, also common in the setting of a long-standing heartburn and reflux esophagitis. Sometimes you may have a patient saying that they feel like there's like a lump in their throat, also known as a globus sensation. That's also another common one. Nausea, not so common, not really frequently reported, but something to ask the patient if they're experiencing. And then also a few less common symptoms can include chronic cough, especially at nighttime, hoarseness, sore throat, laryngitis, asthma-like symptoms, and dental erosion due to acid exposure. These would be more, you know, severe symptoms that you should be looking out for, as well as the symptoms under alarm symptoms such as trouble swallowing, choking, vomiting blood. These would warrant urgent evaluation. Physical exam findings, they're usually nonspecific and unremarkable. Patients may be seen, having a benign physical exam. Vital signs will be stable. The one thing that you can see is that their BMI is, over 25 or 30. They're either overweight or obese. History taking is critical with patients experiencing GERD symptoms. Want to know if they're smoking, what their lifestyle is like. Again, are they eating out every day? What's their typical meal during the day? Are they eating close to bedtime? And then patients with complications or extra esophageal symptoms, you'll notice some epigastric abdominal tenderness, wheezing on pulmonary exam, pharyngitis or laryngitis, and dental erosion. Again, those are uncommon, or they're seen with patients that have complications from GERD and should be evaluated right away. Differential diagnosis. So here we see we have first achalasia. Seen up to 15% of patients evaluated for dysphagia are found to have achalasia. Some of the symptoms with this that you'll see from patients are difficulty swallowing, chest pain, regurgitation. Again, there are some common similarities between GERD symptoms as well. These conditions affect the normal movement of the esophagus, leading to similar symptoms to GERD, like dysphagia and chest pain, but with different underlying pathophysiology. A few diagnostic tests that can rule out achalasia are esophageal manometry, which measures muscle contractions in the esophagus while swallowing and shows how well the ileus opens during swallowing. You can also do a barium swallow test, where the patient will swallow the barium pill or the chalky liquid. This can show if there's a blockage in the esophagus. And then, of course, upper endoscopy, which a lot of these differentials are used. Upper endoscopy is used to rule out. So a camera is used to visually examine the upper GI system to look for any blockages and also collect sample of the tissue, aka biopsy. Cardiovascular abnormalities, especially with the patients that are reporting chest pain, we want to rule out that cardiac etiology, as GERD symptoms can mimic cardiac conditions, so you want to rule out the big, bad, and scary. Something easy that you can do in office is an EKG, shows the results right away. If that's abnormal, you could do further cardiac workup or send the patient for cardiology referral. Eosinophilic esophagitis. Sorry, that's a tough one to say. This is an immune-mediated inflammation of the esophagus, presenting with dysphagia and reflux-like symptoms. Often requires a biopsy for diagnosis to differentiate from GERD. And again, similar symptoms to GERD, such as dysphagia and reflux. Infectious esophagitis. This is swelling and irritation of the esophagus. Common causes are fungi, yeast, viruses, and bacteria. And other examples, HIV, AIDS, medications that can lower the immune response, such as steroids, long-term antibiotics, alcohol abuse. Unlikely, but should be ruled out. And again, an endoscopy would be used to rule this diagnosis out. Diagnostic workup. So for GERD, there is no gold standard. However, some may say the ambulatory pH testing is eventually the gold standard for GERD, but GERD does not have to be diagnosed with any specific test right away. If the patient presents with classic symptoms, diagnosis can be based on those classic symptoms alone. However, those without classic symptoms should be evaluated for further follow-up workup. The evaluation of a patient presenting with GERD symptoms begins with a detailed clinical history that focuses on understanding the type, frequency, and duration of the symptoms. It's important to identify factors that worsen the patient's symptoms, such as their timing after meals, whether symptoms change with body position, for example, upright versus lying down, and potential dietary triggers. History, again, is vital with these patients. It should include any previous efforts at lifestyle changes, as well as the use of acid-suppressing medications. Typical GERD symptoms such as heartburn, regurgitation, atypical symptoms should be differentiated, and providers should be on alert for alarm symptoms like difficulty swallowing, anemia, GI bleeding, or unexplained weight loss, as I mentioned in the previous slide. These can be more indicative of a serious condition or complications that require more invasive testing. A diagnostic endoscopy or EGD is recommended within 2 to 4 weeks if the 8-week PPI or proton pump inhibitor trial fails, or if the symptoms reoccur. Also, if patients, again, present with alarm symptoms, you want to complete that diagnostic testing right away. And then any patient suspected for Barrett's esophagus, you'd want to refer them for an EGD. If the EGD is negative, we would move on to another type of testing, which is ambulatory pH testing. This is a recommended next step for those, again, who have negative EGD, but their symptoms are continuously bothersome. One common form of this test is wireless pH monitoring, often referred to as the Bravo system. It's where a small wireless sensor is attached to the esophagus about 6 centimeters above the gastroesophageal junction, as shown in this picture on the right. This allows continuous acid exposure measurement for up to 96 hours. For accurate assessment, patients are asked to stop proton pump inhibitors at least 7 days before, and histamine H2 receptor antagonist at least 3 days before the test. This helps provide a more exact or precise evaluation of reflex exposure and symptom association. And so further information on the pH testing, a pH threshold of 4 or below defines acid reflux. So it's usually the acid exposure time that is the measurement, and it represents the percentage of total monitoring time during which esophageal pH is 4 or less. So an acid exposure time of 6% or greater is diagnostic of pathological acid reflux consistent with GERD. Again, this testing enables objective confirmation of reflux in patients with unclear diagnoses after endoscopy and guides treatment decisions, especially in those with non-erosive symptoms or refractory GERD. And then lastly, we did mention this briefly on the slide before, esophageal manometry. Patients with chest pain and or dysphagia should be offered this diagnostic test to rule out esophageal motility disorder with those who have a normal AGD. Plan of care. So for starters, it's always important to have goals for what the patient's plan of care should be. Again, these could be modified or tailored to each individual. Relieve their symptoms, promote healing of the esophageal tissue, prevent complications such as Barrett's esophagus, educate the patient on lifestyle changes and medication adherence, and then support them through the nutritional decisions and overall well-being. Dietary and lifestyle changes are typically first line. If the patient says that they have tried everything, they've changed their dietary habits, they've been exercising more, trying to lose weight, and nothing's really helping, you want to start them on a PPI therapy. Recommended is omeprazole 20 milligrams or anything under that proton pump inhibitor, depending on patient preference and what they're on already for medications. So they would want to start taking this once daily for 4 to 8 weeks and see if they have any improvement. If they're not having any immediate improvement, the dose can be increased to twice a day during that 4 to 8 weeks. And it can also consider an addition of a H2 receptor antagonist or over-the-counter antacid as needed to help minimize acid production further. However, proton pump inhibitors, these are the most effective and widely recommended medications for treating GERD. They work by inhibiting the gastric acid production, and they're indicated for both initial symptom control and maintenance therapy. If symptoms do not improve with that medication regimen, that's when you would consider further diagnostic testing, as we mentioned on the previous slide, such as EGD, ambulatory pH testing. You can also send the patient for a GI consult. And then last resort would be surgery. Surgery is the last resort. Patients could be a candidate if pharmacological therapy is not working. The goal is to strengthen the anti-reflux barrier. There's a procedure called the Nissen fundoplication up where the upper stomach is wrapped around the lower esophagus. This can provide permanent relief from reflux. Again, it's not as common. Usually patients are put through all the diagnostic testing first before surgery is even indicated. Non-pharmacological plan of care. So again, encouraging weight loss in obese and overweight patients. You can recommend them to diet programs, encourage exercising or maintaining some kind of physical activity 3 times a week, whether it's walking or doing a yoga or workout class in their house, tracking their calories. Another 2 examples of diet programs include Akram's Lifestyle, which is 2 regular meals a day and consumption of only liquids in between. This avoids hyperacidity induced by meal on top of meal, and also prevents delay in gastric emptying. That study was done by Randhawa et al. 2023, and they were shown some positive effects. So this could be an option for patients that are, maybe overeating or eating too close to bedtime. Also, according to Kroner et al. 2021, the Mediterranean diet has also proved to help with GERD-like symptoms. Moving onward to diet control, again, avoiding foods and beverages associated with an increase in heartburn symptoms such as chocolate, coffee, spicy foods, tomato, alcohol, high sugar foods, fatty foods. Provide resources to quit smoking if indicated, or at least reduce smoking. if they're smoking a good chunk of the day. And then lastly, minimize alcohol intake. On the left here, you'll see some other non-pharmacologic treatment strategies for GERD. Plan of care, patient education is very important. Ensure that the patient's taking the PPI properly and making sure that they're taking it at least 30 to 60 minutes in the morning before eating anything. They want to avoid meals 2 to 3 hours before bedtime, especially heavy meals. Avoid lying down immediately after eating. Avoid trigger foods or beverages, as we mentioned on the previous slide. They can elevate the head of the bed if they're experiencing more nighttime GERD symptoms. They can use a 6 to 8 inch block under the legs of the head of the bed to kind of increase it a little bit, or use a foam wedge under the mattress. It's important to go over the side effects of PPIs. Although they're not common, it's still important to educate the patient if they start experiencing constipation, gas, nausea, diarrhea, vomiting, or headache. And of course, long-term use of PPI use, if the patient is not experiencing any relief from them, they should be communicating that with the provider. Since long-term use can cause diarrhea, pneumonia, anemia, osteoporosis, and cardiac arrhythmia. So it's not helping the patient any, then should not be putting the patient at risk of developing these conditions. And of course, notify the provider if symptoms are not improving, worsening, or experiencing any side effects from the medication. These are a list of all the references I used throughout this PowerPoint. And I thank you all for listening to my presentation of GERD. If you have any questions at all, please feel free to write them below, and I will be happy to answer them all. Thank you. I hope everyone has a great day.